Hi, everybody. Good morning and welcome to the CCSP Family History Screening Tool. So thanks so much for joining. I know that we have several CCSP partners and definitely a couple of interested others from other grants and our Cancer Coalition. So we're super excited to have everyone joining in. On behalf of CCSP, I'm Andy Dwyer, the Program Director, and joining me today on the panel of discussants are Elsa Waltzine, who's part of our CCSP team. And I'm really excited to introduce a colleague who we've worked together closely over the last 5 years or so through the National Colorectal Cancer Roundtable. And I've known Heather's work in genetic counseling and hereditary family screening and the like through Dr. Dennis Anand and many of our team members who are genetic counselors. So we're really excited to have Heather joining us today, who's going to share the update of our family history screening tool that we're utilizing for implementation in the CCSP grant. But we've also shared our strategy for thinking of implementation of this work within primary care. And many of you, I think, are joining on to learn a little bit more about our implementation strategies, the tool itself. So we're really excited, and then complicit with making sure that we're instead with the current guidelines, and there have been review since our last update. It's quite timely for us with our medical advisory team to update this group. And so Heather's helping lead out this charge. We want to thank the team at CU and the Hereditary Cancer Center with Dr. Dennis Anand, as well as Lisa Koo, Lisa and Axel, and several of the other members in another grant series who really helped develop the foundation. But in addition, now we have Heather, as well as 2 or 3 additional national experts helping us really think about this strategy as in Colorado and through many states throughout the country are thinking about better identification of genetic and familial linkages. So we'll have Heather introduce in just a moment, and then also we'll be sharing some data and outcomes too. But to get us started, I'm just going to go ahead and give a little bit of a framing, a reminder that the tool that we're utilizing is really to think about implementation in a primary care setting in a risk assessment strategy in terms of understanding the chances of developing cancer, possibility of cancer in a family, meaning hereditary, possible genetic testing. So if someone were to identify possibly in need of looking like there might be something that's going on from a genetic or familial syndrome, when is testing appropriate? And Heather will go into these in more depth. And when is testing useful? And then ultimately thinking of the counseling genetic combination and what that looks like in terms of a strategy. And then ultimately, we also just need to understand that this is a screening tool and it's used in general conjunction with provider input, and that we're doing our best through this tool to identify those that are most high risk, those that have clinical or interventions that might help identify, but that no tool right now is of course perfect. And so we're trying to do a nice balance between this program and others about the types of questions that really yield the biggest information opportunity, that really think about how do we really address the things that we can do things about without a tool that just becomes so burdensome that we can't implement within practice. So just as a reminder, through our CCPD grants program, part of our effort is to really work with 3 to 4 different clinic systems to implement for proof of principle. It's gone pretty well. We've had some ups and downs, but we're really excited about ultimately what we're learning from the tool itself, and we think we're really being able to identify a tool that works well in practice. So I'm going to just give next slide a quick overview. Heather's going to dig down, but really essentially the tool that we're working for is about 10 questions with a yes/no approach, and then really thinking about addressing first and second degree relatives. And Heather's going to walk through us a little bit question by question, the background based on NCCN guidelines, where we're coming from for the specific questions, who we're really trying to target in terms of people knowing family histories. So we're really excited about being able to move this ahead. We do think this will be a great contribution for our work in Colorado. And I think with other programs, we're really trying to think about a uniform strategy of how we assess family history. So this is some really great food for consideration. And again, to our CCSP partners on the phone, This is the version of the tool that we will be implementing in the 2020-2021 grant year. So with that, Heather, I'm going to turn it over to you to introduce, and we'll start digging into the instrument background and topics. And again, a huge thank you to Heather and her expertise and to be able to bring this work to Colorado. So Heather, take it away.
Thanks so much, Andy. It's really a pleasure to be here, guys, with you today and to talk about the most recent updates to the tool. And I always say one of the things I love about the NCCN guidelines is that they are so up to date. They really are constantly reviewing the literature and revising them. But the downside of that is the flip coin that we have to revise our tools accordingly. And so that's why we've been through a very large revision this year with the tool. There was quite a large revision to the breast ovarian guidelines this year in particular, and that resulted in some changes to the tool to keep it in alignment. So we will go through how these were developed today and why, you know, some of the things that we look for here are red flags that a family history of cancer might be hereditary. And hopefully that will make the tool easier for you to use. And that's kind of usability is one of our goals too. And also when I'm sure when she goes through at the end, some of the data, and I'll explain during the talk, some things that we've added because we found that certain items weren't as usable in original earlier versions of the questionnaire. So Elsa, if you want to go ahead and forward to my next slide. So basically a lot of things combine together, guys, to lead to your cancer risk. One of them is family history, and that's obviously what we're going to focus with on this tool. And that's because it's low-hanging fruit, right? Everybody has a family history. Most people know their family history of cancer to a better or worse extent. And we would hate to miss anyone who was at high risk for cancer based on their family history. In a recent paper from Samir Gupta's team, they found that more than half of colon cancers could be prevented if a family history had been taken and people had been told to start their colonoscopies at the right age and frequency. But there are other things that influence our risk for cancer, such as lifestyle, things like smoking, alcohol use, exposure to human papillomavirus. Those things can increase our cancer risk. Genes are really tied in with family history, but most of the time we're looking for what we call high penetrant genes that have a high risk for cancer. We know there are thousands of other genes that slightly increase the risk for cancer, and those, they're just starting to work on those. And there are these things called polygenic risk scores now where you look at, you know, dozens of small genetic changes that just slightly influence the cancer risk. And they may be very useful for families that don't have a high risk cancer gene running in the family. Then environment, certain exposures, where you live. People from Australia have a higher risk for getting melanoma. That's the downside of having beautiful sunny weather. So all of these things contribute to cancer risk, and all this tool focuses on is family history. So I think it's important to know that if somebody doesn't get referred to cancer genetics based on their family history, that doesn't mean that they don't have an increased risk for cancer based on one of these other factors. And those are obviously things that I'm sure you guys are used to looking at in primary care, for example, smoking and trying to get people into smoking cessation programs. But this tool will focus on family history. Next slide, please. So cancer is very common. 1 in 2 men will get a cancer in their lifetime, and 1 out of 3 women. That's if you include non-melanoma skin cancers, but it's very, very common. What we're trying to find out is, are there individuals in your practice that are at higher risk for getting cancer than the general population based on their family history? Next slide, please. In general, age is our greatest risk factor for cancer. So as we age, our cells divide and we accumulate genetic mistakes naturally as part of the aging process. These aren't mutations in the genes that we were born with, and we can't pass them on to our children, but they just acquire in our body during our lifetime. And so they always say age is your greatest risk factor for cancer. And here you can see the percent of new cases of cancer really increasing per decade of life, up through 65 to 74 when it peaks and starts to come down a little bit after that, probably because those people have exhibited some sort of resistance to getting cancer if they've lived that long. But age is our biggest risk factor for cancer, and so certainly that is with or without a positive family history. Next slide, please. When we look at family history, we think that if you take kind of any cancer, about 5 to 10% of the cases with that cancer will be hereditary. So due to a single gene mutation that's causing that caused that individual to have a high risk for getting cancer in the first place. And this is a mutation they were born with. They inherited it from their mom or their dad. So it's in every cell of their body, and they can pass it on to their sons and daughters. And we'll talk more about that in a minute. There's always this sort of additional 20 to 25% where we call it familial. If we test them for all the known cancer genes, they test negative, but there's more cases of cancer in the family than you would expect to see by chance alone. And this is probably a combination of those minor genes I talked about and shared environmental exposures. People in the same family tend to live in the same place, eat similar diets. If someone's smoking in the house, they're more likely to smoke. And so you have these shared risk factors within a family that make a familial cluster. So there are these familial clusters who test negative for the strong hereditary cancer genes, but there still is a slight increased risk for cancer in their family due to this combination of things, which we aren't as good at testing for yet or quantifying, but there are good guidelines for starting those individuals maybe with their screening a little earlier or more frequently than they would have if they didn't have some of those risk factors. And then luckily, most cancers are not hereditary or familial. About 70% are what we call sporadic, meaning that they occur by chance alone. And again, here, age is our greatest risk factor in these acquired mutations that we accumulate over the years that eventually will cause the cell to start growing funny, not die when it should, and become a cancer. But these are things that occurred in our body during our lifetime, and we can't pass them on to our sons and daughters. Next slide. So just to drill down into this a little bit more, those cases that are sporadic, so the 70% of cancers that occur by chance alone, they are due to what we call somatic mutations, which is a fancy way for saying they occur in our body during our lifetime. So they don't occur in our eggs or sperm. They're like, if you get a breast cancer, they've occurred in a breast cell. If you get a colon cancer, they've occurred in a colon cell. So they cannot be inherited. They cannot be passed on. I always say these take a little longer to acquire. So we tend to see later ages of diagnosis because a person may acquire one mutation in a cell during their lifetime, and maybe that cell dies and nothing comes of it. But if that cell lives long enough, it gets enough mutations in sort of a multi-step process, it will eventually get some sort of growth advantage, not die when it should, and become a cancer. So again, those gene mutations occurred in the tumor only. They weren't born with them. They cannot pass them on to their children. These are the mutations people look for. If you've heard of people getting tumor testing now, it's very popular to try and identify actionable therapeutic targets if any of your patients have cancer and they go see the oncologist, particularly stage 4 cancer patients who aren't responding to standard therapy. They'll often sequence the tumor, and they're looking for these somatic mutations that were acquired that are driving that cancer that they could potentially target with a therapy that is really directed to that mutation. So that's a different kind of testing. That's not the kind of testing I do in cancer genetics. I test people's blood or saliva to see what mutations they were born with that could have caused their cancer in the first place. So that's these mutations that you see on the right side of the screen. So we call them germline mutations, which I just recently found out that patients don't like because it sounds like germs. But when we say germline here, we're meaning that it was in the eggs or the sperm from their mom or their dad, and so they inherited that mutation. And when you inherit a mutation from your mom or your dad, it's in every cell of your body from the day you're born. So most of these genes are genes that are involved in protecting our body. So they're good genes. We all have them and we want them to be working. Some of them work on repair. I do a lot of work with a condition called Lynch syndrome, and those genes are literally the spell checkers in your body. So every time a cell divides, it has to copy all of that DNA exactly, and it makes mistakes. Again, normal part of the aging process. But we have these built-in spell checker genes whose whole job it is to recognize if one of those mistakes occur and repair it. So they are very good, just like when you're typing an email and your spell checker is fixing the spelling for you. You want these spell checker genes doing that for you as your cells are dividing to make sure that your DNA doesn't acquire any mutations. So they're good genes. We all have them and we want them to be working. So if somebody inherits a copy from their mom or their dad that's not working, that copy that's not working is in every cell of their body from the day they're born. The good news is they have another copy they inherited from their other parent. So, and that copy will be working because this is pretty rare. You tend to only get a mutation from your mom or your dad, not both. And the working copy is going to compensate for many years and those repairs will get made. So that's why with most of these hereditary cancer syndromes that we're going to talk about, we don't see childhood cancers because for many years that working copy will compensate and everything will be fine. If it's a spell checker gene, the spell checking will happen. The trouble is that we are aging and we are accumulating genetic mistakes, and the odds are pretty high that just by bad luck, one day over the years, you'll acquire a mistake in that second working copy, and then you have a cell that has no more spell checker or whatever the protective function is, and that cell then can become the cancer. So this is a multi-step process, but if you're born with one of these germline mutations, you're born one step closer to getting a cancer because you have that mutation in every cell of your body from the day you're born. And importantly, you can then pass it on to your future children because it's going to be in your eggs or sperm, and so your children will have a 50% chance of inheriting it themselves because you've got the one copy with the mutation, the one without. You've got to give them one of the two. You have no control over it, and that's why most of these genes are inherited in a dominant way, where there's a 50-50 chance each son or daughter will inherit it. Next slide, please, Elsa. So this is also the reason that for many of the characteristics that we see in the hereditary cancer syndromes. So because they are inherited, you usually have multiple generations affected. So when I take a family history in my clinic, I'm much more worried if I see a grandparent, a parent, a couple aunts and uncles, and then their child with cancer. That vertical pattern of transmission through multiple generations is a red flag that there might be a gene getting passed down through the family that's causing an increased risk for cancer. That's more concerning than a couple siblings. Maybe you've got two sisters with cancer, but their mom and dad didn't have cancer, their grandparents didn't have cancer, none of the aunts or uncles. That feels less like one of these autosomal dominant genes where you can see it getting passed down through the generations. You're also obviously going to see multiple people affected unless it's a very small family. So there are always caveats. If it's a super small family or if it's a syndrome that causes female cancers and there aren't a lot of women in the family, things can hide. But typically, if you've got a nice sized family, you should see multiple individuals with cancer if it's a hereditary cancer syndrome, not just a single person with cancer. We're also going to tend to see earlier ages of diagnosis. Because these people are born with that one mutation and they're kind of one step closer to getting a cancer, it doesn't take as long on average. So they're more likely they'll get that second hit and get a cancer at an earlier age. So we typically say anything under 50 is early, but as you'll see in the guidelines that we've picked, depends on the cancer what the ages are that are going to warrant a referral. Another huge red flag that your patient might have a hereditary cancer syndrome is if he or she has had more than one cancer during their lifetime. And when I say that, I don't mean like one cancer that spread to another organ. For example, colon likes to spread to the liver, breast likes to spread to the bone. I'm talking about two new primary cancers that are unrelated to each other. Because as we mentioned, 1 in 2 men, 1 in 3 women will get a cancer during their lifetime. That's not uncommon. But when you start to see people getting 2 unrelated cancers or more, you start to feel like there might be an underlying susceptibility that, you know, more than just bad luck or chance is at play for someone to have gotten a cancer 2 or 3 different times during their lifetime. So that's a big red flag that your family that you're working with, your patient, might have a hereditary cancer syndrome. Rare tumor types are more likely to be hereditary. For example, breast cancer in a man, not very common at all, and in and of itself warrants a referral. Ovarian cancer is a less common cancer and has a high proportion that's hereditary, more than the 5 to 10% I talked about on the pie chart. More like 20% of ovarian cancers are hereditary. So for years now, they've recommended any woman with ovarian cancer get referred for genetic testing. Medullary thyroid cancer is a very specific type of thyroid cancer. The more common kind is papillary thyroid cancer, which is fairly common in young women. Medullary is very much less common and highly likely to be hereditary. 1/4 of cases of medullary thyroid cancer are hereditary, but you're not going to come across that very often in clinic. Metastatic prostate's not really uncommon, but for some reason they have recently shown that metastatic prostate cancers in particular are much more likely to be hereditary than a prostate cancer that never metastasizes or spreads outside the prostate. So you're going to see that reflected in the guidelines. And then certain cancers tend to run together, and this is a harder thing to know. I think that people have done a good job in the press of kind of letting the public know that breast and ovarian cancer run together in families, particularly since Angelina Jolie had her big New York Times op-ed about having a BRCA mutation and having breast and ovarian cancer running in her family. So I think that's more well known. I don't think it's as well known that breast and ovarian cancer, the same genes also increase the risk for prostate and pancreatic cancer. And that's been some of the changes to the guidelines this year for NCCN, is to really incorporate that pancreatic cancer and prostate cancer risk. And then I think very few people know about the link between colon and endometrial cancer, which is also known as uterine cancer. People just don't make the connection that, oh, my dad had colon cancer and my sister had uterine, they might go together. And that's just as common as a syndrome as the breast and ovarian cancer syndrome, but just less well known. And so if you see those combinations, that can be red flags that the family might be hereditary. Next slide, please. Okay, so how does genetic counseling and testing help both the doctor or your healthcare team and your patients? So basically what will happen is, if a patient says yes to one of the 10 items on our screening questionnaire, they will get referred to genetic counseling and they'll see someone like me, and we literally spend 60 to 90 minutes with them combing through their family history in great detail. We take a 3-generation family history, we draw a pedigree on the computer, we will get medical records if there's a questionable diagnosis that may affect the risk assessment, and from that we'll be able to decide if genetic testing is appropriate or not. And if it is, and it typically will be for any woman you or man you refer for meeting these 10 questions, because by definition, if you say yes to any of these questions, they actually qualify for genetic testing as well, which is good too, because it means their insurance coverage should be good for the test, and we'll be able to order then and get testing results. And based on that, we'll be able to classify the patient as fitting into either that sporadic category, in which case you'll get a letter back saying, we tested them, they're negative, we don't think this family history is hereditary or familial, and this patient can follow the general population screening guidelines. So American Cancer Society guidelines, whatever you follow in your clinic, things like annual mammography at 40 or colonoscopy every 10 years starting at 50, just the general American Cancer Society screening guidelines. Or we might say, okay, this family tested negative for hereditary cancer genes, but we don't like it. There's a little cluster here. It seems like more than we'd expect to see by chance alone, and they need a little bit more screening than somebody without this family history. So for example, if somebody comes to us and we do gene testing, it comes back normal, but they had a mom with colon cancer at age 50. We're then going to want that person to start their colonoscopies at 40 instead of 50 and repeat them every 5 years instead of every 10. So you will get a letter back explaining the patient's tested negative, but they're in this familial category, and this is the screening guidelines that are recommended, which would be different from the general public. So helpful for you guys to know to get them on that right screening pathway. And then in the most extreme cases, the 5 to 10% that are hereditary, where we find a mutation in a gene that causes an increased risk for cancer, they are going to have very intensive surveillance guidelines, starting colonoscopies as early as age 20, going every 1 to 2 years if it's a hereditary colon syndrome. For breast cancer, women will start MRIs of their breast at 25, add in the mammograms at 30, and maybe even consider risk-reducing mastectomies, or removing their ovaries once they're done having children to prevent their ovarian cancers. So you get very specific recommendations based on the NCCN guidelines and your patient's test result about what screening they need, so that then you guys can kind of be the quarterback for getting those referrals made so that they can get all of those necessary screening procedures done. And it's, you know, really potentially life-saving for you to get your patients in that right risk bucket and make sure they're getting the right risk assessment and screening and management. Next slide, please. Okay, so what happens in a genetic counseling appointment? So I gave you a little hint. So we take a big family history, as I mentioned. We may, again, review their medical history too. There are things we may look at in their pathology from their cancer, if they've had one, or their family member's cancer, that might make it more or less likely that their cancer is hereditary. We'll do a big portion where we do education. So we'll explain how cancers can run in families and what is the likelihood that that patient's family is hereditary. We have risk models that can give exact percentages of the likelihood that the person might test positive. Then we'll go through the testing, really an informed consent process, where we'll explain what the genetic testing results might or might not tell them and how they could be used. Also, the limitations of the testing. You know, sometimes these tests give ambiguous results, and it's good for people to know that going in. And that kind of will help us judge too how large of a genetic testing panel we want to order for the patient. The larger you go, the higher the chance of getting one of those ambiguous results. We'll give the patient healthcare options and support options based on their results. And kind of, it's all on a consultative basis. So we'll get letters back to you with what that management should be, and we can help you identify appropriate referrals if you need them. And then we'll choose the right test and proceed with the testing and get that all coordinated and get the insurance coverage checked out, and walk the patient through that process as well if they decide to proceed with genetic testing. And that can be done either by blood draw, or we're doing a lot of our genetic counseling remote since COVID, and we can send saliva kits to their home, and they can just do a saliva collection and get their gene test that way. And I don't know if it's on here later. You probably have a list of all the genetic counselors you guys have available to you in Colorado. But if your your patient has an out-of-state family member who might be the better person for testing, this website you see on the bottom of the screen, which is so easy to remember, it's literally www.findageneticcounselor.com. You can type in any city, state, you can put in cancer, and a list of cancer genetic counselors in that state will come up. And so it may be that your patient doesn't meet the guidelines, but their mom or their aunt does. And this would be a way to find an appropriate place to refer the mom or the aunt if they're out of state. Next slide. Okay, so the background to the 10 questions on the tool. So they are based on this National Comprehensive Cancer Network guidelines. So that is what we refer to as NCCN. It is a group of comprehensive cancer centers who belong to this organization. They send a subject matter expert to each guideline that's being developed, and they have guidelines for treatment, but the two guidelines that we're going to refer to most here have to do with genetic/familial breast, ovarian, pancreatic, and prostate cancer, and then there's another genetic/familial colorectal cancer guideline, and we're going to use those two for these questions. And we are using the very latest versions that came out in 2020. So this is the most up-to-date version of the guideline. And as I mentioned, they get revised at least once a year, sometimes more than once a year, which is a challenge for keeping up to date. But you do know that they're constantly reviewing the literature and making adjustments as needed. We do not capture, as Andy said early on, every single criteria in the NCCN guidelines. We know from experience that some of them don't perform very well on a questionnaire. For example, it's a guideline to refer people that have more than 10 adenoma colon polyps. But if you ask a patient if they've had more than 10 colon polyps, 75% will say yes, even though they haven't. And so that's not an item that performs well. So because of experience, we have omitted items that either don't perform well, or they're so rare and arcane, they're not going to pick up enough patients that it's going to make the tool longer than it needs to be unnecessarily. We wanted sort of the the minimum set of questions that will identify have the maximum impact. And to that end, there's another experience that they've had with the tool that's led to some of the adjustments that you're going to see as well. And so that is family history of female cancers or gynecologic cancers are significantly overreported. And people mistakenly think cervical cancers are ovarian or uterine cancers when they're not. And cervical cancers are very unlikely to be hereditary. They're usually caused by human papillomavirus. So if someone mistakenly says, oh yeah, my mom had ovarian cancer at 25 and she lived to 80, that probably wasn't an ovarian cancer. It was probably a cervical cancer, but they would meet the guidelines because anyone with an ovarian cancer in their family gets referred. So we've kind of adjusted the tool accordingly. And if somebody has ovarian or uterine cancer, you're going to notice we actually have a minimum age that it has to be over. And that's because below that age, they tend to actually be cervical cancers and not ovarian or uterine cancers. And this has helped the tool to perform a little better. And I'll show you when we get to them about that. And then age of onset of cancer, we've talked, it does help us determine if the reported cancer is accurate. And so this is that same thing that ovarian cancer almost is never, it's not never, but it's very rarely diagnosed under, say, age 30. And so we were able to add some age criteria to help us really suss out what's probably cervical and not ovarian or uterine cancer so that we get a little bit better performance of the tool. Next slide, please. Okay, so this is what the NCCN guidelines look like when you open them, and they're a little overwhelming, to be honest. You can see there's a whole page of bullets and numbered criteria here. And so distilling this down to its sort of the best, most impact was what we've done. And we have an advisory group of medical advisors that helped us to kind of get this tightened up and decide on what the final version of the tool was for this year. But what you can see highlighted in yellow are the ones that we have chosen to include on the 10-item questionnaire. And you will note that we don't have everything circled in yellow. But again, these are the best performing items and the easiest ones to ascertain. So the first one you'll see there is that a breast cancer diagnosed at age 45 or younger warrants referral for genetic counseling and testing. Okay, so that's a very easy question to ask. And you'll see that we ask it not only about the patient, but also about their close relatives. So that would be usually on our tool, we're using first and second degree relatives, which we have defined on the tool. But first degree relatives are sort of one step away from you. So that would be your mom or dad, brothers, sisters, and sons and daughters. They are first degree relatives. Second degree relatives are 2 steps away from you. So like your grandma and grandpa, or your aunt and uncle, or your grandchildren. So kind of 2 steps away from you. And so if anyone, if your patient or any of their first or second degree relatives meet these criteria, that's enough to warrant genetic counseling or testing. And again, if your patient's mom is maybe the better person to test because she's the one who had breast cancer under 45, if she's willing to go in, that's fine. You can start the testing with the mom and not your patient. But a lot of times that doesn't work out. And so it's easier just to send your unaffected patient and we could coordinate the testing from there. So the next yellow box you'll see is that if you have breast cancer at any age and you're Jewish, that warrants referral. And that's because we know there are 3 mutations in the BRCA1 and BRCA2 genes that are more common in Jewish individuals. And that makes Jewish individuals more likely to test positive regardless of their family history. So we don't have an age requirement on breast cancer for Jewish individuals. We also know that if there's multiple cases of breast cancer in the family, so 3 or more, that they're more likely to be hereditary. So you're going to see that reflected in the guidelines. We talked about any case of male breast cancer warranting referral because that's rare. So you'll see that reflected in the guidelines. We've talked about any case of ovarian cancer warranting referral because at least 20% of ovarian cancers are hereditary. So you'll see that reflected in the criteria. And then the next 2 boxes are new things to the criteria in the past couple years. And that includes pancreatic cancer at any age. It is rare. It is like possibly hereditary. It's not as high as ovarian cancer, but it can change treatment for the patients themselves. So it is now the policy in many places to offer testing to any pancreatic cancer patient. And the new one then with prostate cancer. So metastatic prostate cancer, which we're going to define as a prostate cancer that has spread outside the prostate. So it's spread to another organ like the bone or the lymph nodes in the area. So a metastatic prostate cancer. The intraductal prostate cancer we feel won't perform well. You would need a pathology report to know that. So you'll see that's the second portion of that line, but you won't see that reflected in the criteria. Same with the Gleason grade 7 or more. Most people don't know what Gleason grade prostate cancer their grandpa had, so we can't use that as a criteria. So next slide, please. Here are those criteria distilled down in the tool. So this is 7 of the 10 items, all come from the breast ovarian guidelines from NCCN. So there you have your breast cancer diagnosed at 45 or younger. Your ovarian cancer diagnosed at age 35 or older. There we've put in that minimum age that it has to be higher than to try to get these not to be cervical cancers. Male breast cancer at any age. Pancreatic cancer at any age. Prostate cancer that has spread outside the prostate at any age. 3 or more relatives with breast cancer on the same side of the family at any age. So again, you've got just 3 cases total that's feeling like it could be hereditary. And then the last criteria that you see on the bottom of the toolkit, tool test is Jewish ancestry and breast cancer at any age. So 7 of the 10 items are straight from the genetic/familial hereditary breast, ovarian, prostate, and pancreatic cancer guidelines. You will also see at the top of the tool that if the patient, their first or their second degree relatives meet these criteria, they warrant referral. And then we've explained in parentheses who is a first degree relative, who's a second degree relative, so you don't have to remember it. Okay, so that means that if your patient had breast cancer at age 40, they warrant referral, but it also means if your patient's grandma had breast cancer at age 40, they warrant referral, okay? All right, next slide, please, Elsa. Now we're going to move to the colon, the genetic/familial colorectal guidelines. So as you know, there are only 3 criteria left on our tool, and they all come from this guideline. So the first one you'll see highlighted there is a colon or uterine, also known as endometrial cancer, diagnosed under age 50. So that, because it's young, is more likely to be hereditary and is going to be reflected on our criteria. We also suggest that anyone who has a family history of a first degree relative or more with colon or endometrial cancer under age 50. So that's part of that same criterion. 3 total relatives with Lynch syndrome related cancers, regardless of their age of diagnosis. So this is sort of like the 3 cases of breast cancer in the same family criteria, but Lynch syndrome is the most common inherited form of colon cancer, and it can cause a number of different cancers, which you see highlighted in the bottom yellow box. The main 4 are colon, endometrial, also known as uterine, gastric, and ovarian cancer, but there's a number of other cancers as well. And so if you have 3 total of any of those cancers in the family, that would warrant referral. So next slide, please. So here you will see these criteria come to play. So colon cancer diagnosed at age 49 or younger. So that's the same thing as saying under age 50, but to be consistent with the breast criteria, we used the at age 49 or younger. And then with uterine, because again, we've had this issue with people reporting cervical cancers erroneously as uterine cancers, we're going to require that the patient be diagnosed at 35 through 49. So technically it's under 50, you saw the criteria, but we find that if somebody says somebody had uterine cancer at 20, it tends to really be a cervical cancer, which doesn't warrant referral. And so that means for this uterine cancer, it's a little tighter age group from 35 to 49. And then the last one is that 3 or more cases total of colon, uterine, stomach, and we've included some of the other Lynch syndrome cancers here: small intestine, urinary tract cancer. And so that could be in the kidney, the ureter, or the bladder. And they have to be on the same side of the family, but they can be diagnosed at any age since there are 3 cases total. And so probably that's maybe the most complicated of the 10 items, because there are multiple different types of cancer you have to look for in the patient's family history to meet that one. The others really are just a single individual. And again, that can be your patient or their first or second degree relatives that have those diagnoses, and that would warrant a referral. Or the 3 cases total one, the easy one is 3 cases total of breast. We would have included ovarian and pancreas there, but they already warrant referral if there's a single case of ovarian or a single case of pancreatic. And so that made this a little more streamlined, and we could just say 3 cases total of breast. With the Lynch syndrome, you don't warrant a referral if there's a single case of small intestine cancer. And so you need to have 3 total of any of those cancers. And so you'll see, you just indicate whether the answer is yes or no, and any yeses at all warrant referral for cancer genetic counseling with consideration of genetic testing. Next slide, please. So this is the gynecologic cancer slide again, just to stress this one more time. Ovarian cancer, so this can be the ovaries or the fallopian tubes, or even a primary peritoneal cancer, which really happens in the lining, the peritoneal lining of the abdomen. They are all related cancers, and that you can see those with both hereditary breast ovarian cancer syndrome and with Lynch syndrome. And when people study hundreds of ovarian cancer patients, somewhere between 18 to 24%, so that's why I'm saying 20% test positive for one of these cancer genes, so highly likely to be hereditary. Uterine / also known as endometrial cancer is associated with Lynch syndrome. About 3% of uterine cancers are due to Lynch syndrome. Some people with uterine cancer do test positive for other cancer syndromes, but Lynch syndrome is the most common inherited form of uterine cancer. But very, very easily confused again with cervical cancer. And cervical cancer is not associated with any known inherited cancer syndrome and is typically environmental and due to human papillomavirus. So this is something that there is no gene test for and doesn't warrant referral. And that's why we are requiring the patients to be age 35 or older, and then for ovarian, and 35 through 49 for uterine to warrant referral. Next slide, please. Okay, so I don't know that we need to beat this with so much, but here you can see sometimes when you're talking to your patient, you can kind of help them figure out which of the cancers it is. And so these are the things to kind of point out. And I'll do this when I'm taking a family history and somebody says to me, oh yeah, my grandma, I think she had ovarian cancer when she was 20. And so knowing what the risk factors are for the various cancers and what the symptoms are can kind of help you figure out if it's that cancer or not. So for example, ovarian cancer patients typically are diagnosed late because the symptoms are vague, and they often will have ascites or fluid on their abdomen and look like they're pregnant. So if somebody says, oh, grandma looked like she was 9 months pregnant before she got diagnosed, that's a red flag to me that it might actually be an ovarian cancer. If on the other hand, they say grandma got her ovarian cancer found on a pap smear, I say, oh, okay, that was probably cervical. Cervical cancer gets diagnosed with pap smears or pap test. And so you see down on the bottom right, we talk about the risk factor for cervical cancer being human papillomavirus. It's not usually hereditary. It is the most common gynecologic cancer, and it most commonly occurs in the 20s or 30s. And it tends to get diagnosed by pap smear. On the contrary, on the top right, you see ovarian cancer risk factors are a family history of breast, ovarian, pancreatic, prostate, colon cancer. It can be due to hereditary breast ovarian cancer, that's the BRCA1 or 2 genes, but it can also be due to Lynch syndrome. And when it says MMR here, that means the mismatch repair genes, which are the ones that cause Lynch syndrome. They're those spell checkers I mentioned earlier in the talk. Ovarian is very rare. It's 1 to 1.5% lifetime risk in the general population. So if somebody has a lot of cases in their family, it's extremely likely to be hereditary, or they may be a bad historian and they're not giving an accurate family history. Epithelial ovarian cancer rarely occurs under age 35, and so that's why we can say age 35 or older for ovarian cancer. And this tends to, the screening tests are transvaginal ultrasounds to look with the internal wand up at the ovaries and look for any growths. They'll use color Doppler like on the Weather Channel because tumors have extra blood flow and cysts are cold and don't have extra blood flow. There's a blood test called CA-125 that's not very good that can be used to screen for ovarian cancer. But typically, because it is not an easy cancer to screen for and there's not effective screening, women at high risk for that cancer often will elect to have their ovaries and fallopian tubes removed to keep from getting cancer in the first place. But again, signs and symptoms, the most notable one that differentiates it from the other two cancers is ascites. And so they'll say, you know, someone looked like she was 6 months pregnant, and that's from the fluid on the abdomen. Then on the top left, you'll see the risk factors for uterine cancer being obesity, #1 risk factor for uterine cancer. And so that can help distinguish a cancer that might be more likely to be uterine cancer. This is associated with Lynch syndrome, as we mentioned. It's not that common, but it's more common than ovarian, probably closer to 2.5% lifetime risk. The average age for Lynch syndrome related uterine cancers is 44. So again, we think it's safe to go from 35 to 49 on that referral criteria. And uterine cancers don't typically get diagnosed by pap smear. Usually people have an endometrial biopsy or a DNC, or sometimes if you're screening for endometrial cancer, they'll do an aspirate of some of the uterus cells to screen them for endometrial cancer. And symptoms usually are irregular bleeding, heavy periods, periods that don't stop. Those can also be the symptoms of fibroids, but if somebody knows somebody had a female cancer and that was their primary presenting symptom was heavy bleeding, it's probably uterine, probably not cervical or ovarian. Next slide, please. Okay, I think this is for Elsa.
All right. And Andy, you were going to take this slide, I believe.
Yes.
Okay, sorry.
Thanks so much, Heather. That was super, super great background on the tool.
Thank you, guys.
So everybody, in the interest of time, I normally have about 10 minutes, but I do want to just remind everybody that in addition to the actual tool, what CCSP and our technical support component has also looked at is really the implementation of the work. So when we look at what we mean by the technical assistance, we need to really think about what is the strategy to get this in patients' hands, to have them complete it, to make sure that we have a provider reviewing, and then we're getting appropriate referrals to our specific partners and genetic counselors, and then ultimately for testing if appropriate based on the criteria that Heather mentioned. We are building off the work of the Generations project that was built out of CU that really looked at that implementation and workflows with Peak Vista. I think also we were looking at High Plains and a few other clinic systems. And then we continue to pilot this approach, but really refining that workflow with the current team-based care and not as much of the implementation of personnel with the generation projects, but really streamlining it for primary care in current systems and with the current types of teams. It's gone well overall. We have had really positive response. We think that the tool is performing pretty well itself, which I think is a huge attribute. And Heather talked a little bit further about the types of criteria that we're utilizing to make sure that we're really on point with identifying those who are most in need. A tool sensitive enough that does that, but not so sensitive that we end up with a lot of people being referred to genetic counseling that might not need it. And then we've also found a really targeted way to implement within the work and role of what the navigator is really looking at and where their specific role is in terms of barrier reduction and access to care, complicit with what we've done with our navigation work. And then, of course, the genetic counselors, once that we have made an appropriate positive within utilizing this tool, have good systems flows, then that handoff and care is something that we worked on as well. So next slide, Elsa. So in terms of looking at that, we have the dedicated 2 to 3 clinic systems that we're working with now. This will give you an idea of a workflow where we really identify when a patient arrives, results of the test, yes, no's, what happens in terms of if someone is screened to found a positive, basically the referral to genetic counseling, looking at the barrier reduction, so transportation, if it's an in-person visit, telephonically, how are we working with folks for genetic counselors? If a patient declines, what are the current workflows? And then I think one of the things that we're also looking at is in our clinic systems, this isn't a one and done. family histories change, what happens within people's, basically family systems of who's diagnosed with a cancer that might lend itself to a yes positive where it had been no before. We're looking at systemic approaches so that it's not just a one-shot wonder. How are we assessing on an annual basis? So this gives you a little bit of an idea of how we've implemented and how we're really looking at the tool working, and then ultimately, what are we seeing in terms of the systems flow from the team itself being able to function to implement this in a way that's efficient, that defines the right people for basically getting to the appointments, no-show rates and the like. So we're really excited to work this through. This is something that we've definitely devoted towards, because a tool is great, but if it's not implemented well, then it doesn't really go anywhere. So I'll have us go to the next slide again, because I'm going to have Elsa and go ahead and share some of our evaluation results to date.
Sure, and I'll just point out a few highlights. So with 2 clinic systems in the first 2 years of the grant cycle, there's been almost 500 patients that have filled out the tool. And out of all of those that completed the tool, 37% initially had a yes response, but following review with the provider and the patient navigator, 76 patients, or 16% of patients, really warranted a referral to genetic counseling and testing. And that's right in line with previous pilot work of the tool and what we would expect to see based on the percentages of patients that are expected to either have a family history of cancer or a genetic risk for cancer. So looking at 15 to 18%, so we're falling right within that with 16%. And as of May, there were 26 patients who had scheduled their appointment, 15 attended, and out of all of those who attended their appointment, 50% ended up getting tested or being eligible for genetic testing, and 4 of those were tested. 1 variant of uncertain significance was found, and the 3 other patients were negative, and 4 patients received updated screening recommendations whether or not they had a positive result from actually getting genetic testing. And so you'll see that these numbers were a little bit on the lower side, and that is because of COVID hitting. And also some challenges in the genetic counseling landscape in Colorado, which we'll touch on quickly. But with COVID, things shifted a little while, and some of those patients that were referred are now getting their genetic counseling and testing performed, and so we should have some updated data soon.
And I want to just know that we only have about 5 minutes left. I do want to see if there are any super pressing questions. We go ahead and entertain those now in the chat. Give people a minute to come off, because we can talk about, you can see the lessons learned. But I think, Heather, what we'll do is if we get some additional questions that we don't have time for today, go ahead and do that online, or maybe even set up for some of the CCSP specific clinic systems who are implementing a Q&A time. But I do want to make just a little bit of space, especially if anyone has any burning questions right now for Heather. I think it would be optimal. Anybody? Are we good? And then I think what I will reserve the right is that if you do have specific questions, especially as one of the programs who are, or one of the clinic systems implementing, please feel free to email. We will also have some dedicated conversations with all of you who are implementing that we can also bring forward questions. So thank you for the, I don't have questions, but I learned a ton. That is a good response.
Andy, this is Guadalupe, but I can't type fast enough. Can I ask a quick question?
Absolutely, please.
Awesome. So in our clinic, we do see a lot of our Hispanic population, and so often they don't know the specific kind of cancer that runs in their family, but they have a ton of history, like grandfather, mother, sister, so on. What specifically can we do to make sure those patients get that attention, since you say that's usually when we start seeing the pattern as it being hereditary, when you can see that kind of ladder coming down? So what can we do for those specific populations that don't necessarily have their family history on hand, or don't necessarily have a quick way to get it due to, you know, coming from like other countries from around?
That's a great question. And you may not be able to check yes to one of the 10 criteria because they don't know the exact cancer. So I would say that's going to be one where make a judgment call. If there are 3 cases total, if somebody's got a young age of diagnosis, that's good enough for me to refer them. You may have to refer them off they won't meet a criteria on the tool necessarily, but if you guys are feeling like a lot of those red flags are hitting, multiple cases, multiple generations, young ages, people getting cancer more than once, something's going on, even if they don't know the exact kind of cancer. We can help them get records when they get to genetic counseling, but if we can't, we also, the gene tests now are broad panels, so they can kind of pick up whatever the hereditary cancer syndrome is, even if the patient's not sure what the cancers were in their family. So I think that's good that you're kind of aware that what the general risk factors are. So if they don't meet one of the 10 items, but you still have concern, you can still absolutely refer.
Thank you.
Okay, so Dr. Anderson, what are the methods to adopt people who have limited family history? How can we train the non-clinical staff who are administering the tool? For suggestions, we'd be to look for cases, cancer in multiple generations, people affected who are young, people who have had more than one type of cancer. Heather, do you want to talk a little bit about that? And I can also share some of the things we're implementing for CCSP this year as well.
Yeah, I think those are great ideas. If they don't have exact information about types of cancer, looking for multiple cases, multiple generations, multiple primaries, early ages of diagnosis, those are the sentinel red flags for hereditary cancer syndrome, even if the person doesn't know the specific kind of cancer. Also, talking through the symptoms and how the person got diagnosed, you may be able to guess what the cancer was. Again, like if they know it was a female cancer and you can get them to describe that she was having heavy bleeding, oh, maybe that's uterine, or she got picked up on a pap test, that's probably cervical, or she looked like she was pregnant, oh, the ascites, and that might be an ovarian cancer. So using what you can, but I know you're saying here this might be non-clinical people doing the assessment, so they may not always know all of those details, but sometimes people will know it's GI tract. There was a blockage, she couldn't eat anymore. So then you can guess that it's GI tract. So trying to look for some hints based on symptoms and how the person was diagnosed is another tip, I would say, other than the ones Dr. Anderson already mentioned.
And then I would also just say that we are going to be also doing a little bit of training around the outreach. And then with our patient navigation tool, we'll be sharing more of that component about good questions to ask, how to ascertain information as well. So, and Heather and part of our team have been involved in part of that review, but we'll try to be rolling out more specific training that way as well. So thank you so much. Can you get a copy of the slides? Yes, Elsa is going to post that. We are going to have this recording. This will be used as our training module for the rest of the year. So we will have this on CCSP site for people to come and learn and share, as well as the slide deck. And then again, Elsa and myself will be reaching out to all of our partners who are part of our work plan to really go through the implementation, that technical assistant workflow approach. And then we will be probably in the next 3 months having a training around the outreach and the navigation component to identify some of the key factors that Katie mentioned as well. So, and that is a good question. And I know we are out of time, and Heather probably has to be some hardware. But the direct-to-consumer testing, I think, we can probably share some perspectives as well. Heather, is there anything else you want to say in closing? Because I think, Katie, that's a really good point. Instead of everybody knows you can get the 23andMe, you can do those sort of pieces that you skip all of what we just talked about today.
Yeah, I will just briefly say that's completely not sufficient. So for example, 23andMe only looks for the 3 BRCA mutations that are common in Jewish individuals. So unless your patient is Jewish, they've had the wrong test. For colon cancer, they only look at the 2 common MUT-YH mutations, which cause a polyposis syndrome. They have nothing to do with Lynch syndrome. So people on these direct-to-consumer things may think that they were tested, but they did not have adequate genetic testing if they have a significant personal or family history. So I think it's safe to say for now that you could disregard it and still refer them, and we'll clarify the difference when they get to us in genetics.
Okay, a huge thank you to Heather, and we will go ahead and make sure that the survey link is vetted, and we'll also have our Cancer Coalition send it around as well. Sorry that it's not working right now. We're over time. Have a great day, everybody. Thanks for such a great turnout, and a million thanks again, Heather and Elsa, and have a great day.
Thanks everyone.
Guys.